Then we'll get it turned over to Jim and get to the content. First, the handouts are available either using the handouts feature through the GoToWebinar app. You can also find the slide deck, this intro slide deck, Jim's slide deck, and the CEU form on the CSOHIMSS website. If you go to Events and Education under Past Events, you'll find the handouts for this webinar and our previous webinars, as well as all past events. For CEUs today, we are able to offer the CPHIMSS and CAHIMSS CEUs. We will also be posting a recording of this presentation on the CSOHIMSS YouTube channel. Usually it takes a day or two for us to get things edited down and up on the YouTube channel. Also, we will be using the integrated questions feature within the GoToWebinar app. So at any point in time, if you have a question, enter it into the questions box. At the end, Jim will answer all the questions. If you can't find the questions feature, feel free to enter it into chat and I'll make sure that it gets relayed to Jim. The CSOHIMSS website, we share a lot of information through there about our upcoming events, link to registrations, you know, some information about HIMSS National as well. You can find that at csohimss.himsschapter.org. Also, if you do have any questions, comments, feedback about the chapter, the events, or you just would like more information, you can email me at csohio.president@himsschapter.org, or if you email csohio.info@himsschapter.org, it goes to the entire CSOHIMSS board. We do make use of social media. We try to share, you know, some information again about HIMSS National, about our upcoming events, and we'll just share some healthcare IT information, some general market information. But you can find us on Facebook, Twitter, and LinkedIn. On LinkedIn, the easiest way to find us really is just log into LinkedIn and search for CSOHIMSS. I do want to take some time to thank our sponsors, because without our sponsors, we could not provide our conferences, these webinars, all the stuff we do throughout the year. You know, we are completely funded through our sponsors, and we just want to take the time to thank them. Our premier level sponsors, our top level sponsors, are EHR Integration Services, Expedient, Logicalis Healthcare Solutions, Sagacious Consultants, Allego Health, Ahead, Cover My Meds, and Merge, and Everest Communications. We'd also like to thank our elite level sponsors, Metasource, Obix Perinatal Systems, and Information Builders, Blue Orange Compliance, Availity, and Tech Systems. Again, thank you a million times over to our sponsors. If you are interested in becoming a sponsor, by all means, please contact me. We love our sponsors. We try to share information about them at every opportunity. Really do our best to make sure that sponsors get some value from us, for their dollars that they give to the CSOHIMSS chapter. I want to go through real quick. I want to share some information on some upcoming CSOHIMSS events that we're really excited about. The next event is the annual Ohio Healthcare Information Technology Day. We call it OHIT Day for short. We've even called it the Advocacy Day in the past. This event will be held Wednesday, April 27th in the Ohio State House atrium. Again, the focus of this event is to advocate to our legislators on a specific healthcare topic. Right now, it looks like it might be something with interoperability or data blocking. We're trying to, finalize our theme and our message, but this event is free. Really, it's a lot of fun. We actually schedule appointments with your legislature and provide you with information so that you can educate your legislature on the healthcare topics that are important to you, the healthcare information technology topics. Watch the CSOHIMSS website for registration and additional information. Our spring conference, we've titled Hack, Is That a Cough or a Cybersecurity Breach? It's a cybersecurity and HIPAA privacy security conference. This will be held Friday, May 20th. It'll be held up in Dublin at the OCLC Conference Center. We are actively seeking both speakers and vendors for this event. If you're interested in both and either, please contact me. We'd like to share some information on our upcoming Lunch and Learn webinars. The next webinar will take place Wednesday, January 13th. Topic will be medication prior authorization. This will be presented by Mr. Scott Gaines from Cover My Meds. The registration link is up. The February Lunch and Learn will be either data analytics or natural language processing from Dr. Albert Lai from OSU. Again, registration link is active. Our March webinar will take place on March 9th, and theme will be the Notice Act, new requirements for observation patients, what your organization needs to know, presented by Mr. Tim Kelly as Standard Register. The April Lunch and Learn webinar will be HIMSS Tiger at the grassroots level. Presenters will be Toria Shaw from HIMSS and Victoria Wanjia Anderson from the University of Cincinnati. Our May Lunch and Learn will be focused on developing your brand, recruiting considerations, and a few other things, as you transition into an HIT role. Ms. Lisa Cannon from the Chartist Group will be the presenter. We are searching for speakers for June, July, and August. So if you are interested in speaking and presenting, by all means contact me. The great thing for the presenters is if you are pursuing either HIMSS advancement to either the senior or fellow status, these webinars count towards your required number of presentation points, and also it just gives you a chance to share the knowledge that you have with others in the CSOHIMSS and throughout Ohio. We have just finalized plans to bring the CAHIMSS and CPHIMSS review course and test to Central Ohio. The CAHIMSS review course will be Thursday, April 14th from 8 to 3, and the CAHIMSS certification test will take place immediately following from 3 to 5. The review course for CAHIMSS is about $150. The certification test varies from $140 to $175, depending on your HIMSS membership type. If you're not a HIMSS member, it costs a few dollars more. CPHIMSS review course will take place the following day, April 15th, from 8 to 3, with the certification test from 3 to 5. Review course, same price, $150. This CPHIMSS review certification test is a few dollars more expensive. It's $270 to $300. There is a typo there that it should say CPHIMSS review test on the left-hand side, but it's about $270 to $300. The host will, this event will take place at Cover My Meds. They are serving as our host for the day and as our sponsor for this event. We would like to extend a thank you to Cover My Meds for providing that this opportunity to the CSOHIMSS members. We are going to be limited to 25 seats for each of the review course and 50 seats for the certification exam. Registration link's not up. Watch the CSOHIMSS website for more information. And lastly, at HIMSS 16, which will be in beautiful Las Vegas, Nevada, the end of April through March 4th, we will be hosting an all-Ohio luncheon. We're partnering with our friends from Northern Ohio HIMSS. This is going to be a free event for all CSOHIMSS and Northern Ohio HIMSS members. It is Wednesday, March 2nd, noon to 1 in the Bellini Room, again, in Las Vegas. Registration link coming soon. With that, I will now be turning this over to Mr. Jim Carroll, so give me a minute here as I make Jim the presenter and unmute Mr. Carroll. Jim, can you hear me?
Yes, I can, and I hope you can hear me and see my screen now.
Yes, sir. We can see your screen. You have the floor.
Outstanding. All right. Thank you, Scott. The topic for today's discussion is protecting electronic health information, and I'm going to be taking it more from the small to medium-sized environments in my details. I will talk to the hospital side as well. But when it comes to protecting electronic health information, I do believe that we always feel that it's mission impossible to get some of our small practices, actually some of our small CAHs, because of their financials, to be able to protect the electronic health information. And we feel as if we're jumping over hoops and jumping through lasers every day. Demographics for myself, I've been 40 years in IT. I was the CIO for Sisters of Charity Hospitals in Northeast Ohio. That stood for the Chief Information Officer, not Chief, because of being Catholic Charity Healthcare, as you know, we were always challenged to be able to have the funding to do what we needed to. I've been directing the Regional Extension Center, which is a program out of the Akron Regional Hospital Association. ARHA has been around 75 years, and in 2010, we opened up the Regional Extension Center. I also lead and facilitate the CMS Privacy and Security Community of Practice. Today we're going to talk about what are the requirements from the Codified Federal Regulations 164. Some examples of the resources and some basic guidelines to assist in completing risk analysis management plans. Through our Regional Extension Center, we've helped over 1,200 physicians and eligible professionals meet meaningful use, and during that time that required us also to be helping them with their risk analysis and management plan, and you'll hear us and me refer to that as a ramp because it's an easier thing for me to say. So let's dive right in to the requirements. And again, if there's any questions, I'm sure Scott will let us know, or let me know. All right, so the HIPAA security rule. I think I'm not a big one to read what's on the screen, but I'll talk to you about what's on the screen. As you know, it's amazing how many of our small practices still do not think the HIPAA security rule applies to them. They don't understand it. They think they're too small. I could go 100 reasons that they're not going to be able to understand why they have to do the HIPAA rule. And when we drive down into this document, one of the first things that I always hear from the folks in the office is they didn't go to school or they didn't train to understand this, and that's fine. We're going to be there. You as health IT professionals, if you're in a security area, you're going to be there to help them understand, and so that they fully can grasp what is it they need to be doing, and how do they meet this rule. Excuse me. So for 2015, a couple things did change, and again, the objective is what always throws us when we're dealing with, as it simply says, protect electronic health information. And now it's created or maintained by the Certified Electronic Health Record Technology. So if that information has been created out of this EHR and it's being stored somewhere else, we need to be protecting it. This is the one that always throws doctors, as you know, into a tizzy, is that they have to understand the Codified Federal Regulations 164.308 and the 164.312, 164.306. Well, as I try to point out to them, those regulations are going to point to other regulations, so don't just think you've got three things to worry about. One of the other things that and I added this is not going to be in your slides because yesterday I had the pleasure of doing a risk analysis for a small practice, 2 doctors, but they were being managed by a larger practice management group, and this practice management person told me that, oh, we know all about our HIPAA requirements. So as I was doing my inventory of EPHI and walking around, I found that they have a Google Doc that the person said, oh, all we have on that is the last 4 digits of their Social Security number and a code that we put on there. And it was interesting that he did not think that anything to do with Social Security numbers was an issue. I think it also, if I recall correctly, had the zip code, which goes to this next slide. And did you know, it's been estimated that if you know the patient's date of birth, their gender, and a 5-digit zip code, that's unique for over 50% of residents in the United States. Now, I wish I could, there's a PhD in Washington who is really a consumer advocate, and I drew a blank as I was looking for her information. She's been studying this for years, and she's done presentations about the greatest breach that goes on every day, about how people don't realize when just these 3 pieces of information, date of birth, gender, and a 5-digit, they are giving away their ID. Notice the difference as soon as we now go to year and gender, and the 3-digit, we drop down to 0.04%. And this goes in line with the comment I had yesterday. May parts or derivatives of any of the listed identifiers be disclosed. So that means if I have this information out there and it is breached, is that okay because it's been de-identified? And the answer is no. Data set that contain patient initials or the last 4 digits of Social Security number would not meet the requirement of de-identification. Meaning, if you lost that information, then you had yourself a problem because you have breach. I think it's when we're doing these with our practices, it is in the small hospitals, it is incumbent upon us to make sure that we train them. There are so many sources of incorrect information, and I don't blame doctors for being confused, and I don't blame them for missing the intent of a risk assessment and management plan. The sad part is when an auditor shows up, especially beginning in 2016, I think they're going to find that they're not going to be quite as tolerant with them. Let's talk about available resources for you when you're out here doing this. So when you go through the CFRs and you're working with the practices, you know, I think it's really important, first of all, that now business associates need to understand they have to protect and do the same things that the covered entity does. And that's where one of my big challenges are with some of these business associates is they do not think they need to do that. They want to charge a practice to provide answers about their doing their security assessments, and that's all wrong. They're supposed to be doing that as part of business associates. Make sure that your locations, your practices, all have business associates agreements that are updated for the post-omnibus rule so that you do now pass that liability and requirement onto your business associates so they understand what they need to do and the impact if they do not do these things. So you need to protect against reasonably anticipated threats or hazards. And I say that this way because I run into some of the providers out there who are working with a third party, and they're anticipating meteorites, they're anticipating flash floods in an area that you don't have. Now, there's nothing wrong with doing that, but let's be reasonable. These practices are challenged to understand this rule, and the more we throw at them, we don't need to confuse them. So let's try to make sure that they understand. They're doing the reasonably anticipated threats and reasonably anticipated disclosures, and make sure that they do understand that CIA is not Central Intelligence Agency. We need to make sure the confidentiality of our data is there, the integrity, that we know it's not being changed, it's not being modified, and we need to make sure it's available. The available portion is a key piece. Many of my practices that I've been through do not understand the needs to have an alternate business site, have a business continuity model. So how will they provide medical records, clinical information for their patients in certain emergency operation modes? Do they even understand what emergency operation mode is? And the last one there, ensure compliance. The state attorney generals, there's a real nice video out on the CR. I should probably put that in caveat. I haven't looked for it for about 2 years. But it actually is a video where the state attorney generals are being trained. And they drive down into, do you have sanction policies? If you don't have sanction policies, the attorney generals are being told, yeah, you can fine. You can add money to your penalty for that. And you can go back for as many years as they haven't had it since 2005. So this is important that they understand their staff. I have not yet seen the auditor come in and do this, although I've heard they do, but they'll come in and they'll separate some of the staff members and ask them questions about their privacy policies and their high-tech IT policies, and hopefully the people know them. If they don't, then I will tell you that they have not trained their workforce, which is a requirement. And that goes under one of the threat and vulnerability statements. Actually, I believe it is number 3. The security standards, and this is where we get into, well, I'm a small practice and I don't have to do it. And that's not true. Reasonable and appropriate. Granted, and I'm going to use the Cleveland Clinic because I'm up in Northeast Ohio, but it could be any of my hospitals did the same thing. We follow exact same safeguards that the solo practitioner with 2 employees does. Of course, it's not reasonable to assume that they're going to have the same level of security as I tell every doctor, but it is also not appropriate that they do nothing. And that's where we come in when we do these risk analysis and understand them, that they doesn't matter what their size is, doesn't matter if they're a 1 or 2 person, they still need to be addressing what's going on with their IT, with their EHR, and with their privacy. And they have to, the business associate now has to apply or comply, with the applicable standards. This is something that if you're working if you're working with a third-party business associate, and how do you determine, we're not going to drill into that today, but there are some good tests you apply to data or to your vendors as to, do they need a business associate agreement, and how frequent, and what must you do? Is it acceptable that your third-party data housing or EHR hosting company tells you yes? Is that appropriate? Or should you ask them to provide proof that they are indeed complying with the applicable standards out of 164.308 all the way up through 16? And the answer is yes, you need to get them to give you something in writing. I highly doubt that they'll give you their risk assessment unless they're a large organization and they're doing some other types of the high trust kind of things. But it is important that these practices understand business associates have to comply, and they are going to be held accountable. They being doctors and the folks in the business associate organization if there's a breach. All right, so we can go down through each of these, but you know, the bottom line here is if it's required, you know, we have addressable or we're going to have required, and the everybody assumes addressable means we don't have to do it. Well, it may mean you don't have to do it, but you have to have a reason why you didn't do it. And if it's required, you better be doing something with that and ensuring there's not that many out there that are showstoppers. They're going to cause you a lot of grief if it's under the required, or addressables are addressables, quite frankly, in a lot of my small practices were able to go with a very basic approach and get those. But when I get some of these larger organizations, the solutions are going to grow. I saw one of your sponsors there earlier in the group, and the other one I really knew by name, Scott, and that was Blue Orange. Blue Orange does an outstanding job on these large medium to large organizations, and helping them meet and understanding what is required, what is addressable. And that's where the professional who does this comes into play. I had this discussion I had, actually I'm doing it tomorrow with a physician who failed an audit because they thought they had done an appropriate risk assessment and management plan, and they didn't. So at this point, they're looking at having 2 years of their incentive dollars recalled. They've only failed the audit for 1 year. My guess, since they failed for the 1 year, they'll go back and audit them again. But we've got to make sure when we're doing these things that we're protecting the end user, the practice. Make sure they understand what they've got to do and what they must implement. We're going to drill down into that in just a second. Under this, again, it's important to understand that when you're doing this, it's reasonable and appropriate. And if it's not, document why it would not be reasonable. And one of the things that the feds are getting a little better about is that they really used to drill this in, and saying it costs too much is not reasonable, is not acceptable. Well, they sort of backed off that, because I think they're realizing that the cost on some of these things, you have to do something. And I'll get a good example. We all have a front door to where we live. Some of us lock them, some of us don't, depending on what we think the risk is. Some of us have more than one lock. Some of us have alarm systems. Each of those are based on the level of risk we think we're facing and what we are protecting. And that's going to be our EPHI and when it comes to a practice, or the PHI if they still have paper charts and a lot of paper-based documents. So it's important that when we work with a practice, they understand if they can't implement something, they need to document why they can't and what they're doing to protect that. Example would be if I can't, many of the practices do not have, a door between their front lobby, their public area, and the backside, the secure area, because a lot of the new offices are in these open designs or even didn't have them built in place. Now, it's not reasonable to assume that they're going to go build a door, but that it would be reasonable to make sure then that we have some policies in place that say, let's keep an eye on, let's make sure that everybody who's working, if it's a visitor, they're given a visitor's badge, that you walk patients to and from the rooms, because you don't want to allow somebody walk back into the secure area where you may have unprotected EPHI because of either the cost or it's in your management plan and you haven't implemented it. So those are some of the simple things that we need to look at, because that low-hanging fruit is going to be the stuff somebody in the world hurt if they haven't attempted to even do that. I could argue I can't afford to put encryption on 25 PCs. It's too expensive. I couldn't argue that I couldn't afford to put a policy in place that says every visitor is never let loose by themselves. Patients are escorted to and from the rooms. There are different things like that that you would look into. These are our administrative safeguards, and this is where the rubber meets the road. I can take you out there, and I see it all the time. They ask, it's much like personality tests or the vocational tests they used to give many years ago when I was a school teacher, that you ask the same question on the same subject a half a dozen times to make sure you get the correct answer. So that's why you can go out and take the federal, use the SRA tool that we helped build out of the community of practice. You're going to find about 130 questions in there for about 42 safeguards. But as the administrative safeguards are defined when we get in here, and you can, you see these types of things here. We've all read them. We can look at them. And the key piece is to understand what is the implementation specification you're being asked to do, and what is the minimum. And again, these are very difficult to define, minimum, because they're written by a governing body who has to fit everybody under these rules. That's why we get so mad in our community of practice when we see words like recommend, should. Either tell me yes or no. Don't give me the choice you recommend it, because I may not think that means I need to do it. Things along that line. It's worthwhile to make sure you know these things. What are these rules? Understand why. Because I ask somebody, do you know who the security officer is? And they look at me like, why? And the whole idea, obviously, behind it is you got to have somebody who's paying attention to the updates, the rules, the guidelines that are coming out, policies and procedures. Doesn't mean you have to do the work. You're just the one who has to know what needs to be done. And then when we drive down into some of these, we get into, this is, if you really want to scare the practice, this comes right out of the NIST standards for 800-30. And you can drive down through. These are all the inputs and outputs. And if you drive, this is what a risk assessment should do. System characterization, threat identification. Now I can tell you, if I'm back at my hospital where we're developing code and we're doing all these kinds of things, absolutely I'm looking at this level. When I go into the local doctor's office that has 2 providers, 4 employees using a canned EHR, there's not a lot that we're going to gain out of scaring them to death. We will drive down through having questions about their system instead. And then when you get information system activity review, this is one of my favorites, because when you get into what's going on, then you'll see what it actually means. And make sure that your audit logs are turned on. It's amazing how many people, that we see all the time, have a third-party company handling their IT support, but this third-party company never looks at some of the devices. They never look to see, are they getting attempted attacks through the firewall? Is anybody looking to see if accounts are locked out? Why are they? And you'll see when you look over here on the left-hand side, the actual CFR, and then you'll see these TVSs. And the TVSs are the threat and vulnerability statements that have been developed. And those are what we always walk through with a practice, telling them these are the things you need to be watching. And they don't all apply to the same level. But make sure when you're at a site, and if you're doing any type of information system activity, or if you're drilling down into this, at least be looking at account lockouts. First question I always ask, so who resets accounts? And it's usually the office manager or it's a third party. When I ask them, how often does that happen? And blessedly, I can say, most times they go, not too frequently. But I do get in some other ones and they'll say, oh, it happens a lot. So I ask them, do you look and see the log? When was somebody trying to log in? And it's amazing how many people don't even think about, oh, I guess we should. Or if you're looking at, are people using your system at off hours? A lot of the EHRs have the capability to block that out. You can set a time of operation for non-clinical, non-critical employees. Most people don't do that. So if somebody anytime during the day could get in and access that information. Physical safeguards. Remember we talked about contingency operations and what would you do? How would you, and again, those of us that do this for a living know that if they're hosted, that takes a lot of the risk away from them, but not all of it. But they should have some form of contingency plan, what they're going to do, and they drill down into this stuff here, and it's pretty straightforward. And so they want to make sure that if you're having any issues in your building and you're in the contingency mode, how are you protecting and what are you doing to make sure that your EPHI is safe and is available? And then the technical. So again, in the technical, when we look at these compared to the administrative, so the big portion that I try to get into with most of these people and these practices and when I'm training people about this is drill into the operations of the organization. If they pull out their HIPAA manual, if they pull out their security manual and blow the dust off it, then, and we see that happen all the time, then we have a pretty good idea that they have not established that this is important. But it's really, right here you can see we got quite a few that fall under administrative, and then the physical drop down, and then technical about the same thing. Encryption is the real big one now. Again, if you have encryption, you are heading in the right direction to not have a breach. And I say that because there was a organization on the East Coast that had a laptop encrypted, and it was stolen, and they still got tagged as a breach because they had the encryption key taped to the monitor. When you opened it up, there was the encryption key. So I always try to warn folks, just because you encrypt doesn't mean it works. And also to make sure that if you're going to use encryption, try to choose something other than Bob's pretty good encryption. Look for one that meets NIST standards. Now, is that a requirement? Yeah, it's written that way, but do they know, the auditors? Is this one NIST standard? Nah. Unless they're getting really good. They haven't known the ones I've run into. But I will tell you, if you're using a encryption methodology that can be cracked by somebody who's an entry-level programmer, then you're not really meeting the intent. You are doing that encryption so you don't have to declare a breach. And that's what I try to drive through to our practices, is to understand you're protecting your information, and if it is stolen, you don't have to declare a breach if you met the requirements. Now, these are all different out there, and if I can't ask, Scott, are you able to answer a question? Don't know if you're muted or not. All right, he probably is. I don't know if these links are live in your handouts you received.
Hey, Jim, sorry, I was muted, but on the handouts that they'll receive, those links are clickable.
Good, good. So you can go right to any of these links, and you'll be able to see what's out there. And what I try to tell everybody is you need to be staying in touch with these because they do change. The feds are out there making changes. Those of us that do it all the time, we see FAQs being updated 2 and 3 times within a couple weeks. And so if you haven't stayed up to date, if you're not paying attention, then you may be giving some bad guidance. And again, notice the privacy practices. Those are all out there. The security, this is that risk assessment security tool. If you haven't used it, it's definitely, it's not perfect by any means, far from it, but it gets the conversation going. What I try to tell folks is, it would be, think about, if you understand enough about IT security, you can do this yourself. If you don't, why would you risk it? Somebody give me a whole set of tools that I could take my car apart, and I'm sure I could start disassembling that engine very quickly, but I'd never know whether I had a problem, or worse yet, I may not be able to put it back together again. So I try to tell folks, leave it to somebody who knows what they're doing, at least the first time. So let's talk about it. This is what I talked about just a moment ago. Is there a specific method? Nope. And this is what drives me up the wall. I see people out there for solo practice, 1 or 2 docs that'll come in there and tell them it'll be $5,000 for us to do a risk analysis for you. Now, I'm not saying they don't get $5,000 worth of value out of it. I'm just saying that's an awful lot of money to be paying for something that probably is overkill, because they're doing all the exact same things they would do. They're doing penetration testing. They're doing all sorts of other testing within the network, and that's all very good. But most of these small practices don't have very many open ports, and they don't have a lot of issues on things like that if they've got somebody there. But again, there is not a prescribed method. But here's what they look for. Establish a culture of compliance. And that's the first thing when I've talked, when we're doing our community of practice, we have representatives from the office of the privacy officer, and we'll ask questions about that. That's one of the things they look for. Is the practice at least trying? Or are they sitting there flipping off CMS saying, no, we're not going to do this? So leadership is critical, and by leadership, I always tell the doctors that they're the leadership most of the times. I have run into some of my small practices where it's a husband and wife team, and for financial purposes, the spouse, who is not the physician, actually owns a business, and the physician works for them. So, but the bottom line is, don't put this on your practice manager or a director unless they have enough time to drill home. And if you're going to do that, I always point, and doctors do not like me very well. They didn't like me when I was CIO and I did this. They don't like it anymore now that they have no control over me, is I tell them, if you're going to just thumb your nose at the rules and expect everybody in your staff to follow them, but not you, that one will come back and get you, because when we have a breach, you're going to be the one who's going to be held accountable. So training and education. It's sad to say that most of our practices do not apply good training and education when it comes to the electronic side of this. Create an audit file. Make sure you know what you've done, why you do it. You've got to have an inventory of all your EPHI, because that is the asset we're protecting. If you do not have a good, thorough inventory, then you've got really not a good risk analysis. Make sure you do a full-scale risk analysis, and that's more than just a checklist. That's walking through and physically validating things. You develop a management action plan to address that. Make sure you've got the right policies and procedures. Have a communication plan with your patients, your staff, and your vendors. It's important patients realize there are areas they're allowed to be in and areas they should not be in. And your same thing goes with vendors, and staff needs to understand the appropriate use and also what they're empowered to stop somebody. And then finally, make sure your business associate agreements are up to date and current. I tell you this, when I talked about the physical walkthrough, we did this recently for a small practice, and they had a terrible incident. A lot of your older businesses have double hung windows, and in the exam rooms there's always something blocking the view, whether it's a blind, a curtain. Well, a young man went into the exam room, unlocked the double hung windows because they were first floor, and then pulled everything back. Nobody bothered to check the windows at night. That night he came in, climbed in through that window he had unlocked, and was in the process of stealing all their laptops if he had stayed out of where their meds were stored. When he got up in that area, there was actually a motion detector. They only had their doors covered and their pharmacy area covered. So these are things that when I look at a practice, I tell them these are where your risks are. So we've tried to use the old SOAP method, subjective, objective, assessment, and plan. That's what our docs understand. We do have a privacy and security checklist. We do go through a risk evaluation then with them about what is the impact, what's the likelihood. We take a look and see what kind of existing controls do they have, and then we will create a management plan. And as we tell them, this is a never-ending, this is not a one-time shot, this is something you need to maintain. When you get into the inventory, we try to tell them here are potential sources of where you might find. Now, this is not limited by any means, but we do tell them they need to understand what is that asset called, where is it located, does it, remember we saw this a little earlier, does it create, receive, maintain, or transmit data? Is it encrypted? Well, then the next piece is critical because that's part of our business continuity. How would we keep things going? Then is it in the cloud or is it local? We do a facility walkthrough. In here we're going to look through and we're going to find out. You have visitor sign-in. It's amazing how many practices do not have visitor sign-in, or if they do, it's simply a date and name. And for quite a while, when I'd go in, I would sign in as Mickey Mouse, and I was only questioned about that one time. What we do is we tell them, you better have enough information, so 2 weeks after the fact of a visitor being there, if your information shows up on the local newspaper, you better be able to say who were all the people who were in that office and why were they there. So you can begin as you do your security incident review. So when we drill into our risk analysis, we ask them things like this. Do you have formal sanction? And these are the things that a formal sanction policy should include. Should drill down in there. And most everybody, because HIPAA's been around for a while, has a HIPAA manual. Well, from our side, there are high-tech issues, security issues. And so we want to make sure that you truly have this in place. And for any of you that are on this call with have children, you know then that, you know, if you don't have some kind of rules and some kind of penalties, if I told my sons that I want their rooms cleaned up before they can go out, and if they tell me, yeah, Dad, we did them, if I don't go check them and hold them accountable, then I'm really never going to train them, or I really don't take being a parent very serious. So the same thing goes here with security policies and procedures. Once you get through those, you then got to develop a risk. And this is just a real brief one. But, you know, what's our risk? We have no formalized sanction process. This would actually go into Threat and Vulnerability Statement 03. And if we go back, you see where it's up there, TVS 03. And the TVS 03 means that we're not setting a priority in the business that puts security at a high level. And so since most breaches occur internal, the risk is pretty high. And so priority, you know, at that point would be medium to high, use information security policies template. We tell them, because one of the things that the NIST standard looks for is who's, you know, what are the resources, who's responsible, when's it going to be done. And this needs to be completed for anything that's not complete, in progress, or unknown. And I said, there are, in our case, a little over 50 of them that we go through just on the in this format. So what's it going to mean for compliance? Conducting and risk analysis, you've got to make sure you have the policies and procedures. Make sure that any EPHI, is encrypted, so it can't be accessed if it's lost or stolen. I did a risk assessment last week. As I walked around, I found 4 CDs sitting on a shelf. And I asked somebody, what are those CDs? And the girl said, oh, those are all the charts and everything out of our old EHR, just sitting on the shelf where anybody could access them, and they didn't understand the risk they were in. Make sure that you understand how to restrict a patient's information from being disclosed. That's one of the things that HIPAA does. Make sure you can provide information electronic. Keep your privacy practices updated. So, I think I got us with about 10 minutes left for questions, Scott.
And we do have a couple questions, Jim. Okay, the first one, it looks like we've got one, but it's a long two-part. So let's hit the first part here. It says, do you see a lot of organizations completing risk analysis through just a risk analysis checklist, or are organizations actually incorporating IT systems technical review, like vulnerability scanning, access controls review, in their analysis efforts?
Okay. The answer, unfortunately, is yes to both of those questions. I say unfortunately because the first one is the one that scares me to death, that they see they download something or they get something from their EHR and they have no idea what they're answering yes or no to. In fact, the practice that I'll be going to tomorrow did that, and when they were audited, the auditor simply asked them, did you understand what you were answering? And the answer was no. And we are getting more of the latter, whether or not it's going to be vulnerability testing, pen testing. I always tell them they need to be validating from a HIPAA perspective who's accessing what. Again, you get into some of these larger organizations that have multiple job roles and descriptions. Somebody needs to be making sure that they are validating why people are accessing things and where they're getting to. There was just actually something that came out today that I saw that addressed that some, oh boy, I'm trying to think where it was, somebody inappropriately accessed 800 patient records.
All right. The second question, you talked about a practice management vendor managing small practice and its lack of understanding of the HIPAA rules. What are your most important recommendations for covered entities for managing risks borne by business associates, IT, and other vendors or partners?
Well, therein, I'll be honest with you, this is a current topic among our community of practice. What can we develop for our covered entities to give them some guidance and a feeling that they're getting the right answers? So the basics are, understand that first of all you have the appropriate business associate agreement in place. That means it's updated after the 2013 Omnibus Rule, and that you are in fact following up, just like you do in your practice, just like you have your training in your organization. You want to hold your third parties, your business associates, accountable that they are, in fact, training their staff. Now, my biggest concern about that is I only know what I know, or I don't know what I don't know. And the fact of the matter is, I could be sitting here and telling you, yeah, I'm doing everything correctly, when in fact, I may be missing and leaving a very large hole in here. I just did a business associate audit out of a group in Arizona, big data center, over 250,000 patient records in there. And they had their stuff together. They knew it. They all from the A to Z, they had everything together. To contrast that, I did another doctor's office being hosted by a local IT company here in Northeast Ohio, and the IT guy I talked to had no idea what his requirements were as a business associate. And as I pointed out to him, the risks he had now absorbed, he was quickly thinking about whether or not he wanted to do that. So the best thing you can do is ask them, provide proof you've done a risk analysis and a management plan, share their education plan with you so that you know that their staff is being there, and question them. You can question them. You're allowed to do this. You're the covered entity. You can ask them, show me everybody who's accessed my patient records. And if it's a third-party practice manager, which was the case that I ran into with this one, it was purely just a matter that this person thought. They applied what they thought was common sense. And, I don't mean to pick on the HIPAA rules, but good Lord all knows they don't always follow common sense.
Well, Jim, that's our last question. I would like to reiterate the audits are occurring for the Meaningful Use program. I personally am working on audits for 4 different health systems. One of those health systems has 4 of their providers being audited. So the audits are occurring every day. The first thing they look at is this meaningful use required security review. And if it's not there or it's insufficient, they don't even bother looking at the rest of the information, and you fail the audit and you've got to return any incentive funds. So it is extremely important. And Jim, I really thank you for sharing your knowledge and your background and your information today. Very much appreciated.
Hey, Scott, what year are those doctors being audited for?
It's all 2014, pre-payment audits.
Well, we just had, it's been a few months ago, we had a 2011 audit. So that's why it's so important for any of you out there who have done these, make sure your audit files are complete and you know they are. Because this practice had lost the original risk assessment management plan that we had done for them, but luckily, thanks to the wonderful guidance of Kathy Rich and Kathy Costello, we had them in our files at our Regional Extension Center when able to provide them.
Well, if there are no more questions, I would like to thank everyone who attended. We'll get an updated copy of the slide deck posted to the CSOHIMSS website. Here in a few days, we'll get the recording of this webinar posted as well. If you do have any questions for Jim, his email address was up on the screen, or if you just email it to me, I will make sure that we get that forwarded over to Jim. And again, we are looking for speakers for future Lunch and Learn webinars. If interested, contact me. So with that, again, thank you to all attendees, and we'll hopefully see you next month.